Welcome to our Caribbean and African Targeted Health Improvement Program, CAHN Health Hour. Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CAHN is funded by the National Lottery Community Fund.
Okay. All right. Good morning, everyone. Welcome to another health hour session. Morning. My name is Eloka. I'm a doctor, GP trainee, helping to host this session. A very unique, niche topic called about focus on health tourism. We have a very experienced Dr. Folake, who is a GP in the NHS and who has a lot of experience, and also as well she's a travel agent, so she has a lot of experience and she'd be able to give a lot of wealthy advice about the expanding world of health tourism. Welcome again, everyone. Thank you so much for joining. I'd just like to encourage you that, just to be as engaged as possible. Any questions, we encourage it. Please just drop any questions in the chat. We have people moderating and looking at the chat at all times, so we'll get around to answering those questions in the chat and Zoom or on YouTube as well. I'd encourage you as well to just maybe drop in any experiences you have with health tourism. Let everyone know about where you're tuning in from, what country, because I know we have viewers from all over the world. And share the link with your family and friends, because this is going to be a very interesting topic today. Okay, Dr. Folake, welcome, and would like to start presenting for us. Thank you.
Thank you so much, Dr. Eloka, and good morning, everybody. My name is Dr. Folake Yusuff, and I am a GP, also known as family physician, based in the United Kingdom. I'll invite everybody to type in where you're dialing in from today. So I have an idea, because most of what I'm going to talk about will be directed more towards people based in the UK. So if you just type in where you're from, and then we can see if there's anything else that needs to be covered outside people from the UK. So while I'm waiting for that, I'm going to start sharing my screen and we can get started with the presentation. Right, so I've titled this health tourism, the good, the bad, and the ugly. So as I said earlier, I'm an NHS GP, so most of the views I'll be giving will be based on my experience working in the United Kingdom. I trained in Nigeria and I did a year after graduation. So I do know about the healthcare system in Nigeria and many African countries as well. So I'm quite aware about what happens in those countries. I'm also an independent travel agent, and I am also a director on a medical concierge company, which is a company that helps people who want to have healthcare in the UK. So again, I know about, people traveling for healthcare, but mainly seeking healthcare in the UK. And forgive me if I make any if I sound like I'm undermining any country, but I do not have any intention to undermine any country's healthcare system. I believe every country's healthcare system is geared toward whatever resources they have and whatever demands that or the healthcare needs of the population. So health tourism is not a new thing. It's something that has been going on for a very long time. Historically, the United Kingdom has been a very popular place for people to come to seek healthcare because it has always been regarded as one of the top safest and efficient countries to deliver healthcare. And if you remember some time ago, for the people that are based in the United Kingdom, say about 2015, 2016, there was, when they were trying to clamp down on immigration, and there was all this shout about people coming for medical tourism, people coming to take advantage of the free healthcare in the United Kingdom. And that moved a lot of things in terms of changing the laws around visiting visas. So I've got family based in Nigeria still, and people coming in as students as well. And they want you to have enough money to be able to support any extra health you need. Health is still free at the point of use in the UK. So that's only if it's an emergency, if you're not based in the UK, but if you needed anything that is considered as routine, then you'll have to pay for it. Also students as well, then they had to start paying a health surcharge, and some people coming in with their families as well had to pay quite a lot of money towards the health care system. So there was all that, who have a health tourism, and then come COVID. Obviously, we're all stuck at home, 2020. However, going just before 2020, the trend of seeking healthcare outside the UK started to increase. And coming up to then, as a GP, we started to notice that there was more demand on the healthcare. The waiting times were already getting longer, even for things like cancer services. Then compounded by the fact that COVID came, and then boom, like nothing was happening. Things opened up, but they were only prioritizing urgent health needs and cancer care. Most routine care should be about 18 weeks wait. They were much longer. And of course, as service users, everybody got upset about it. You expect, we're paying our taxes, we're paying, towards this publicly funded healthcare system, and we're not getting what we need. It doesn't also exclude GP appointments as well. It became harder to get GP appointments. And there was just this general dissatisfaction about the NHS and publicly funded healthcare. So people started to look at alternatives. So going to private, UK private healthcare, which some people were lucky to get from their workplaces. But obviously, if you don't have workplace covered insurance or personal insurance, it was very expensive to get. And then came these other countries that were already kind of in the background, but they were not big on it. They then came in massively to take advantage of the fact that, there was a market growing in the UK. Now, I've listed some common destinations that people go. However, this is the official list from 2016. So I must say we don't know exactly how many people are going abroad for healthcare to seek healthcare out of the UK. But their estimate as of 2019, obviously they're estimating it to be about 300,000 plus, but we know that it's much more than that. Also, with the countries that have been listed, again, we don't exactly know because there's no formal register of where people are going and how people are going. I was reading some of the documents about health tourism, and the only way they know is by surveys that people fill in the airport when they return, saying, I don't know, like, where have you been and what have you traveled for? And that's only a small percentage of people that fill those surveys. So we're talking about 1-2% of people. But even from that, we still have this large number of people saying that they've gone out for healthcare request. So a lot of EU countries and then Turkey as well. India is there. I do know personally some people going to other countries like South Africa as well. The other thing that has changed the requirement or the demand for healthcare outside the UK is newer procedures that they don't really have a strict guideline, and they're not well commissioned, or they're not commissioned at all on the NHS. So things like, fertility and gender, obviously cosmetic surgery is not funded by the NHS as well. And weight loss actually should be on that list. The other big one is dental treatment. Again, we know how hard it is to get dental appointments. As an NHS patient, you end up having to pay as a private patient, and even as a private patient, some of the things are quite expensive as well. So again, there's a lot of, disgruntlement with the system, and people are feeling like they can go into other places to get what they need. So why are people going abroad for healthcare? So one, obviously, is the cost, as I said earlier. The UK private healthcare system is great, but you still have to pay a lot of money for it. So if you're fee paying, by the time people add up the cost of the procedure when they go, and the travel and the stay, sometimes, or in most cases, it's still cheaper to go abroad than to stay in the UK. Obviously, waiting times for the NHS. And then I've put a postcode lottery, and that's a term that is very common amongst the medical, in the medical world, in terms of some things in some areas are funded and some things are not funded. So if you live in a particular area, you might be able to get something, but some people in another area can't get it. And obviously people are not happy about that. Then obviously with COVID, there is, the globalization of things, and, people are online more, people are seeing what people are able to get outside the UK, and they're like, okay, I can actually get something. I can actually get this. All I need to do is go to this country, and I just have to pay for it. And there I am. The marketing, obviously, we know about influencers and social media as well, especially with the cosmetic industry, the weight loss industry, the hair transplant industry we're talking about that just before we started is becoming a big thing as well. And because of the impact of COVID, a lot of countries are looking for newer ways of getting revenue in. Every country suffered a hit financially through COVID, and so they're looking for ways of getting new revenue into their country. So again, health is a big one, and the NHS is one of the oldest, I think, and I think only one of the few standing free at the point of use healthcare system that we have at the moment. So there's so much eyes on the NHS, and anything the NHS cannot do, people are just waiting to grab on it. So at the moment, people are organizing massive health expos in the UK, just to try and attract people to come to their countries for healthcare, for healthcare. Some people are having satellite clinics as well in places like in places like London and Manchester, just to recruit, I would say, patients and send them to their countries to get their healthcare needs. And then some countries have also made it easy to come for medical. So if you're coming for something medical, you have a medical visa, you don't go through so much hoops to be able to come to their country. And obviously we can't forget the fact that, even though the NHS is great, there are other expertise that we don't have in this country that other people have. So the more you do something, the better you get at it, essentially. And obviously there's the accessibility to, things like fertility treatment, and things like gender treatment as well, because again, the laws around some of these things here can vary. And obviously the right to choose. People have to feel, well, I've got the money, I can make my decisions, I can do whatever I want. I don't need the government telling me I can't do this or I can't do that. I don't need my GP telling me what I can do or what I can't do. I can do whatever I like. So there is the other aspect that is easily forgotten, which is called diaspora medical tourism. And this is a situation where people go to their home country. So when people have migrated to a particular country, say I've come from Nigeria to the UK. UK is my host country, right? So I know about Nigeria, I know what's available in Nigeria. And if I have a problem, it's easier for me to think, hang on, what's available in Nigeria? Let me go and see what's going on there. So there's a lot of this. So people say, oh, I'm going home, but they don't exactly say what they're going home for. And there's a lot of medical tourism in that population of people. And that's obviously is not accounted for, by statistics. And there are lots of reasons why people would want to go back to their home countries to go and get healthcare. One, obviously, they're with family, so if they're going for something like fertility treatment or like major surgery, they have they have loved ones around them to support them, to help them to do to do things as well. So it helps them on that road to recovery, unlike when they're in another country where they've migrated to, where they're alone, they've got their kids, they've got work, there's so many demands and there's so much stress. You have that, kind of mini holiday away from the stress of life. You can do your surgery and you're fine. You also know the healthcare system very well. You know who, you know how to navigate the system, you know the good people and the people that are not so good, and you can get what you think is good quality and value for money. And I've put their bread and butter. So it's also about expertise. So we know, again from COVID, and I reference COVID a lot because it was an eye opener even to the healthcare system in all the countries, that there are some inequalities in healthcare. And obviously that's why CAHN has put on this kind of programs to make us familiar with some things that are particular to the Black and Caribbean ethnicity. So things that are more common amongst your own population or your own culture is easier to address in that country, because the doctors there are well aware of it. It's what they do every day, and it's easier for them to do it. And also, obviously, the cost as well is cheaper because, again, the UK is one of the stronger currencies. So if you go to most other countries, whatever you can do in that country, you can do more with the money that you take, and you have the support of family as well. So now, what are the constraints and what are the concerns? So in the UK, which is the only first world country I've practiced in, particularly, I know that the healthcare system is highly geared towards favoring the patient. So there's so much regulations for us as doctors, and we're most likely we're more likely to be seen as the wrong ones compared to something blaming the patient for anything that goes wrong. So the patients are highly protected, long and short of it. So we've got the GMC, that's the General Medical Council, we've got the NMC, which is the Nursing Medical Council, and we've got other professional councils as well. And most of them, yes, they're called Medical Council and Nursing Council, but if anything, they are getting more towards protecting the patient, safety, and making sure that we don't act outside our remit. And with all this, the patients get a better deal. Now, if we go to other countries, you might not get the same level of protection that you get in the UK. You also have quality of care that will vary. Like, how do you know what level of care and quality that different countries have to safeguard the kind of procedure that you're getting? We have things like ethics. So, for example, the laws in this country that protect donors of certain organs, even to people that they know, or even to people that they don't know. Some other countries, you might be able to donate those organs by paying a fee, for example, which in the UK is highly legal, regardless of whatever agreement you come. Surrogate mothers as well. So surrogate is where a woman or a couple, and usually the woman that will carry the baby, cannot carry the baby for various health reasons. So they get another woman to carry that baby for them. And in some other countries, you can find these people who are kind of low income earners, and they pay them money and sometimes exploited for whatever reason. But in the UK, there's so many laws around surrogacy. This is very, very protected, and it can be quite an expensive venture to go into. So again, what are the ethics? What is there in place to protect you as the patient? I'm sure we all remember not long ago, there was a diplomat from Nigeria who came in and got somebody else to transplant a kidney for their family member. And it was a big thing in the news because that kind of arrangement is highly legal. Even though the person was brought in from Nigeria and was given some money to keep him quiet, he realized that actually the law here does not allow this. And he decided to come out with that. And obviously this person is now, has now been has now been charged because they've done something illegal. But in another country, they will get away with it, and that poor person would have lost an organ. Access to records as well is another thing. So again, we have electronic records in the UK. Everything is there. Now we have the NHS app, which makes it easier to access your clinical record, but not everybody has access to everything that they need. If you had to go to another country, there might be something important that they need to know about, or if you've gone to get some level of secondary care, which is not digitalized, so the records are still paper. If you don't have everything you need to be transferred to the next hospital that you go to, then you might be at risk with that. And we've got medical mishaps as well. These things happen, mistakes happen in medicine, whether surgically or non-surgical procedures. What happens? What kind of system and structure is in place to protect you? Here you've got rules around that. You've got, the steps you take to get clear compensations, or if you want to make a complaint. If that happened abroad, it can become a very expensive venture to try and get any compensation, or even make sure that you actually get your case looked into properly. So there are lots of issues that can come about when all this framework and safeguarding measures that I mentioned in the last slide are not looked into properly. So when people go abroad to go and have procedures, and I work as a GP and I get this quite a lot, they come back and they come with this whole list of medications and letters to say, oh, this is what the patient have, go to your doctor and ask them to do X, Y, Z. Now, if the procedure is not licensed in the UK, you're going to struggle to find somebody to take over the care of that or the aftercare from that procedure. So because of the medical legal aspect, as I mentioned in the last slide, we're meant to work within our capacity. So you then fall into a situation where you're stuck in the middle, basically, because now somebody has said you need this, but then I've said, well, no, I don't know anything about this, and I'm sorry, I can't help you. So what then happens to that person? Do you then go back to the country you're coming from to go and get that whatever aftercare you need, or not? What happens? We don't know. Also, we have inappropriate procedures. So again, lots of marketing, influencers, or Facebook targeting. I know Facebook ads is one of the ways that they get, these companies get people, and they tell you that, oh, this is, this is your problem and this is a procedure that you need. And then it ends up being, you don't know, because obviously you're not a specialist. And then you go over, you have this procedure that you really didn't need to, or it wasn't appropriate for you with your other medical problems that you had. So again, that's another thing that people get frustrated with the NHS. Like, oh, it takes a lot of time. I went to the consultant and they said, oh, I can't have this thing. And people get upset about it. But if you think of it, that at the end of the day, they're looking at what is safest for the patient. And if anything goes wrong, yes, they can get into trouble, but also you've got the rest of your life to live with if that problem occurred. Medications, so on that, it's the type of medication. So people come with, all sorts of weird and wonderful things that people prescribe abroad. Now, medicine is different in all countries. So if one doctor in country A says you need this, you might go to country B, and that's not what they do in that country, or maybe that medication is not even available, or is not even licensed to be prescribed there. Then what happens? And funding for procedures. So again, people, when you have a procedure in the UK, obviously, if it's on the NHS, it gets funded and everything gets sorted out. But the way the funding works is we've got the primary care, we've got the secondary care, and we've got the tertiary care. So your GP will be your primary care, secondary care will be your most hospital consultants. You've got tertiary care for very specialist things like fertility or heart problems and things like that, or transplant. So if you've gone abroad to have fertility, say, for example, you've gone to have fertility. Now you've bypassed the GP, you've bypassed secondary care, you've gone straight away to have a tertiary care procedure. Then we come back to the UK and say, oh, I've had my fertility treatment. The doctor has said I need to have X, Y, Z. Now you've come to see me as a primary care physician. I have no clue as to what you're talking about. Now I have to refer you back to somebody who knows what to do with you. And don't forget you're pregnant and the weeks are counting. It doesn't mean because you've gone to have this procedure abroad, you're going to jump the queue. You're still going to be referred as usual. Of course, except there's something urgent. Yes, it will be sent as urgent, but there's going to be a delay in your care before you get to the person that is actually going to do it. Now, the other thing that then happens is, well, somebody has done something, somebody else has to then look after you. Who's going to then take responsibility for if something doesn't go wrong? Where are you going to, or the other person that is tasked with taking over says, well, I'm not sure what this person did. How do you then mediate between those two? And there's so many things that I think, we're just not at that level yet. And people get really, really angry and frustrated when they get to that to that point. So for instance, I had a patient who went to, I was actually fertility treatment. She went abroad for a fertility treatment. Now, I'm not sure what kind of package she got, but it was one of those that she had the treatment and she was back in the UK maybe a couple of days. She didn't even wait to see whether the treatment had worked or not. And she came to see me and she said, it was a telephone actually, she said, here you go. The doctor has said, I need to have this blood test. And people come in then demanding to have something. And you can't, and I also explained to her that I cannot take responsibility for what I haven't done. So you telling me to do a test because somebody else has said you need it doesn't mean I'm going to do it because I'm not a puppet. I'm a professional as well. If I do not agree with this test or I don't know what to do with the result of this test, then I'm then seen to be acting outside my limit and outside my competency. So, I mean, obviously in those kind of situations, you understand the frustration and you meet in the middle. I ended up doing the test for, I said, look, I'll do it for you. But the problem is I don't know anything about the result. So your doctor will still need to interpret the result of this test to you. And you can imagine, obviously she's had fertility. It's quite an emotional thing, but that's the difficulty it is. So, it's the difficulty on that side where when people come in and think, oh, because I've seen a specialist and they've said I need to have this scan or I have to do this, then it has to be done. It might not be done. The person you meet might not be, feel comfortable to do it for you. And that causes a bit of unhappiness, of course, on your end as well. There's also the issue of foreign illnesses, as we know, when we go abroad and we come back, we bring in all sorts of things. I mean, I'm Nigerian, we're always bringing in malaria every time we go back home. But the other things as well that we bring in too. And again, not being the country where that particular problem, that particular disease is endemic, then it causes a problem. And there was a time, I think it's easier now in the UK, but I remember maybe about 10, 15 years ago in the UK, when you come back from places like African countries with malaria, they take you to a special unit and then you're kept in, like you're very infective and they treat you like you've brought in this weird, virus that everybody's going to catch or something. So it is better now. Obviously, it's not the same, 10, 15 years, but it's still the same thing, when common things occur commonly, when you go to a GP and say, oh, I've got a cough and a cold, those are probably viral, we'll treat you as viral, but maybe you're carrying something else that needs something more urgent. When you've had surgery as well, there's also some rules around flying after surgery because of something we call deep vein thrombosis. So that's blood clots forming in your veins because you're not moving, because you're at high risk of forming blood clots after surgery. So when you've been stationary for a long time, i.e. long distance travel, you're more likely to form blood clots. You've also got pulmonary embolus, which is blood clots in the lungs as well. So again, that's another risk that you get exposed to when you go abroad, and this has to be looked in by whoever is managing you to make sure that you're fit to travel. Not all surgeries, obviously, so please don't get worried. Some surgeries are fine, minor surgeries are okay, but major surgeries, you definitely need some time before you can travel, or you need some extra protection as well after the surgery. Managing complications is another nightmare that we face as well as GPs when people come back to the country. So a lady came the other day, she'd gone to have liposuction. So liposuction is when they take out the fat from the skin in usually in the belly, sometimes in the thighs as well, to make you have, is what they call tummy tuck. So make your tummy flatter, more firm. She came in to see me some weeks after, and she had this massive abdominal pain, like it was really tight and tender. One, obviously, I don't know anything about, tummy tuck. I'm not a plastic surgeon, I'm a cosmetic surgeon. How normal is this for somebody to have this kind of thing? Is this normal to have it, a few days after surgery? I'm not quite sure. I said, what ends up with this kind of people, they end up in A&E because again, waiting time to see a specialist in a clinic is going to take about maybe 3 months, maybe 4 months, urgent, maybe 1 month. Obviously, this cannot wait there because as a doctor, I'm thinking worst case scenario, could it be an infection? But why would she have an infection 3 weeks after having surgery? It doesn't fit. But anyway, she was shipped off to A&E. She had all the tests done and they couldn't find what the problem was. She came back home and a week or two later, she came back to the surgery again and she was seen by one of my colleagues and she messaged me and said, I don't know what to do with this lady. She came to see you and she's come back with the same thing again. I said, well, looking at all the tests she had in the hospital, there's no infection there, which is a thing I was worried about. There's no blockages from the scans that she's done. So there's nothing urgent. Unfortunately, she's going to have to wait to see them in clinic, which wouldn't have happened if she had the surgery in the UK, because then she will still have the aftercare from the consultant that did the procedure. And I could have just written to the consultant and said, Mrs. X had this procedure, a few weeks ago. She's coming with this. What do you think? Does she need to come in? And then we can have that easy correspondence. But for a patient they've never managed, they've never met before, it's going to be hard for them to take a decision. They are going to have to see her properly in clinic and decide what to do. There was another lady who I saw as well who had a procedure in India as well. And she had same thing. She had for a female, she went for a female procedure and she ended up having some blood in her tummy. And she came in again with tummy pain. And I had sent her into A&E as well. She was, managed as an infection and something more serious. But coincidentally, this was also picked up after she had the surgery in India. So it wasn't a new thing, but it was one of those, at that time, there was nothing they needed to do about it. Just said, keep an eye on things. And now she's come and then it was still there. And she was very frustrated and very anxious, as you can imagine. She kept on calling the surgery so many times. And we just had to say, look, there's nothing else we can do. You just have to wait and see how things progress. And that anxiety also comes from the fact that she's not sure that we are attending to her properly and maybe we're missing out something. And for some reason, she couldn't correspond with the doctors who saw her previously. And so those are the kind of things that we have to think about. What happens when there's a complication? What happens after you've had a problem? What kind of aftercare is there? And I'll talk about that in subsequent slides. And I put on their social responsibility. And I think with all these things that, I've mentioned, yes, on one hand, one thinking is, well, we should, the healthcare system should be grateful. We've gone abroad to pay for this treatment that the NHS should have given me. I've paid all my taxes. But there's a flip side of, yes, that's if it goes well. What if it all goes wrong? Then the NHS has to pay much more to rectify that problem. But there's also the fact that that person then has to live with that, whatever happens on the side. And patients are now having to, look into that and balance the risk and the benefit of actually going abroad to go and do whatever treatment they have. And I understand being a patient, when you're living with something, you're living with a condition, you need some answers, you need some cure. And I'm not in no way blaming the patient, but I'm also saying it from the other side so that we can look at this in a more holistic manner. So I've just put a few things together in terms of how, things that you probably will be helpful to keep you safe and make sure you have the best deal of wherever you're going. So one is, obviously, do you really need the procedure? Because then we go over things and some of them, do we need them? Are there other ways to manage that? In the UK, we're pushing more towards lifestyle medicine for a lot of things. Even though people will still have, weight loss procedures, weight loss medications, the mainstay is actually lifestyle medicine. It's lifestyle, changing the way we live, the kind of things we eat, the amount of exercise that we do, how active are we, what kind of unhealthy things we're eating as well, sugary foods, refined foods, alcohol, excessively. Those kind of things are going to impact our healthcare to a larger extent than surgery. I've met people who have gone abroad to have surgery, and the ones that have had surgery in the UK, both for bariatric surgeries, weight loss surgery, and it worked, drastically. They've lost weight, and after some months they start to gain weight again. And that's because the foundation hasn't been looked into. The habits that people have need to change to make the bariatric surgery effective. And yes, when people ask and say, oh, I've been waiting for the NHS, it's like 12 months to get to see, more than 12 months in some places really, to get to see a weight loss specialist. and they're frustrated. Yes, I understand the frustration on one end, but on the other end, why that is because they have steps for people to get to before they get to the bariatric treatment. So that's for weight loss treatment. Obviously, there's cosmetic treatment as well that people go for, and you know, I'm not I'm not in any position to determine whether somebody needs a cosmetic procedure or not, because obviously it's all about, how you perceive yourself and what you feel you need for your self-esteem. But sometimes we just have to sit back again and look and think, do we really need this? We see people that get very addicted to cosmetic surgeries, and they do one thing and they do the next thing and they do the next thing, and it just keeps spiraling. Where does this stop? When you don't have the right legal framework in place to stop people from experimenting with other people's bodies, people are going to take chances on your body, especially when there's a financial reward at the end of it. Even in the UK, where we think that things are very strict, you can't do this, there's so much regulation here and there. A few months ago, we heard about this poor lady who had went and had what did she have? Was the injectable, isn't it, under the skin, the one that they used to improve the hip curvature, and she then had infection and died as a result of that. So, and that's just one case that we know. There's so many other ones. There's the one that somebody had lip injection, lip filler, and then she had the injection went into the blood vessels and caused a big problem. So that's even in the UK. That's where we think that the regulations are strict. What about countries where there's no, anybody can just open a shop on the street and call themselves whatever? It's going to take some time before the government comes to find them and make sure, and see that, see that they've been doing something wrong. The other thing that helps is getting, referrals and references. And it's not only, oh, I know this good doctor here, go and meet him, because some other people work on referrals. So if I refer a patient to this doctor, they give me money for referring the patient back to them. Now, in the UK, apparently that is illegal. So as a doctor, I cannot get a kickback by referring a patient to another doctor for a particular treatment, because that means I'm not being objective in my opinion and my referral. This happens a lot in in other countries where one person will get a kickback for referring a patient onto them. So then you keep getting referred for various things. How do you know? This person says, oh, Dr. Joe is a good doctor, go and see him, he can sort you out. But that's because Dr. Joe is giving me something, not because I know objectively that Dr. Joe is a good person. So there's what they call the referral, asking people, getting the soft information about how a particular clinic is, or how even the doctors, not just the clinic, is the doctors as well that is going to be working with you. But there's also the hard ones where you actually ask them for what are the outcomes, what are the mortality rates, what are the complication rates, the continuity of a package of care. So what you're paying for, it might be cheaper, but what does it cover? Does it cover does it cover the full range of things? What if something goes wrong? Where do I stand? Who's going to pay for that? So for instance, I go to have a simple, straightforward procedure, and I'm talking of on the NHS in the UK, and it can happen in any other country as well, but I'll say the UK. So I'm going to have my appendix taken out, for example. Okay, appendix is an urgent one. Let's use something that's not urgent. So I'm going to go and have a lump that is not a cancer taken out, right? So it's a very simple, straightforward procedure. Everything usually goes well 99% of the time. Nothing happens to anybody. However, there are a couple of things that can still happen along the way. I can fall ill by no fault of anybody. I could just pick up something in the hospital. A simple day case procedure where I should have gone and come, I end up staying in the hospital for 4 or 5 days because I've got, an infection that by nobody's fault. Or I lose more blood than I'm supposed to lose. Then they have to transfuse me and I have to stay for longer on the ward. But then when the dangerous thing that happened, maybe a mistake happened. So they cut something that shouldn't have been cut, and so i.e. a small surgery then becomes a major surgery. And for lots of reasons, people can stay longer than that was planned. What happens then? And these are the realities of people going for surgeries, no matter how simple they are. So what we need to do is check those packages when they come. It's not just a procedure that looks cheaper, but it's also everything else that goes around it. And that's one of the reasons why private healthcare in the UK is expensive because it has to cover for every eventuality that can happen. There's some procedures that are pretty much straightforward. So I work in allergy, for example, and we always do what we call a skin prick test. So it's basically, we just put a tiny needle under the skin to see if you're allergic to something. No big deal. I can do it in my bedroom if I could. However, for you to be able to do that kind of procedure by our regulators, you have to be prepared that things can go wrong, because this is an allergic person. What if they had an allergic reaction and they became unable to breathe? So anybody that's going to provide that treatment has to be able to provide CPR. You have to have resuscitation equipment available. You have to have easy access to ICU. Now, this is why this cost rise, because somebody has to pay for it. Somebody has to pay for all this equipment that we have to do just in case. But because they value lives of people, one person dying, so many people are going to answer for it. So these are the kind of things that make these things expensive. So what is in your package? You need to know. You need to ask them, because if something goes wrong, what then happens? Who pays for it? Not once, not twice. I've seen posts on Facebook where people are making all these videos looking for donations for somebody that, oh, they just went to somewhere and something happened, and because they didn't have enough money, they are running into debt. The hospital is charging them more money and they can't bring the person back home. The other thing is, obviously, that brings you is travel insurance, which I didn't put there. Or did I? Yeah, I did insurance, but travel insurance, very, very important. So not just insurance to cover the healthcare, your travel insurance as well. What does it cover you for? And make sure all the links are covered, whichever insurance that you're provided. Everything is covered along the way, because anything can happen at any time. We as doctors, we see this so many times. Something that was so supposed to be something so simple, something so straightforward, ends up becoming a big deal. But because NHS is free, we do not appreciate the amount of things that go into caring for these kind of patients. We don't appreciate how expensive these things are. One night on ITU in the UK is, even for the healthcare system, is costing thousands, about £15,000, and I think that's even much more now. So you can imagine how much that will cost, and somebody has to pay for this. So please look at that package when it comes. They might just be quoting you the cost for the procedure, assuming nothing goes wrong, but you need to look at the fine print as well. Travel vaccines, don't forget that, obviously. That's something we do anytime we're having to travel anywhere. So always make sure that you go to the travel clinic, either if your GP surgery provides that, that's great. Or if you have to do that privately, lots of chemists do that these days. Tell them where you're going. It's easy, they'll find the vaccine for you. Please don't leave this too late as well. Again, people forget about this, and then they come to the surgery and say, oh, I'm traveling tomorrow, that I need this. Well, one, they won't be able to get you an appointment. But secondly, some of these vaccines have to be used so many days or so many weeks before you actually travel to give you the protection that you need. The other thing is language, and I get this more with our Eastern European patients who go abroad, and that this is where the diaspora medical tourism comes in. They go abroad very easily to go and get healthcare. And what I understand about the healthcare system there is you pay for it. So I hit my toe on something and it's hurting. Well, I feel I need an X-ray, or I feel I need a CT scan. You could easily access it by just, almost like ordering for it, basically, or you find somebody to get you to do it. So they come back, and a lot of people come back with all these discharge letters saying all sorts of things. Well, it has to be interpreted. So if you're coming back from a country that doesn't speak English and you're coming back with a discharge letter, the responsibility lies with you to get that letter officially translated. There are official medical translation companies that can do that for you. But the main thing I put there, I said independent interpreter. So when we have in any procedure, you have to do what you call consent. So i.e. you're happy for that procedure to be taken. They tell you about the procedure, they tell you the risk and the benefit and what can happen and XYZ. Please make sure you get an independent interpreter, because again, you need to have that independent opinion as to what's happening. You don't know the language. They brought you this person telling you that they're an interpreter. How do you know what they're saying, and how competent are they at interpreting what the professional is giving you? So please make sure that you get somebody, an independent interpreter, to be a mediator between you and the person who is doing the procedure for you, and make sure you speak to the person that's doing the procedure. Again, that is another important thing. You need to have that feel of the person that you're going to work with. You're paying your money for it, for God's sake. So please make sure you meet the person, you know what they're doing, you know what they're talking about, and you're confident that they can go ahead with the procedure. And I put it on there as well, next of kin support. This is a very big one. Again, some procedures are seen as everyday now. So like hair transplant, like even the bariatric weight loss surgery, cosmetic surgery, people go, they come, within a weekend, they're back. But as I said earlier, things can go wrong. What if something goes wrong? What if you woke up the next morning and you had an allergic reaction and, you need that support for somebody to be there to look after you? You don't want to be alone on your own where people are taking advantage of you and you're incapacitated and you cannot make those decisions yourself. So please go with somebody else because it just makes life so much easier for you. So the last one I put there is, if in doubt at any point, do not hesitate to say no. So we've had people saying, oh, I went to go and see this doctor or this person, and I had this feeling that things were not right, but they still went ahead to have the procedure. So please, if it's your body and you don't know what's going to happen to you when you're under the knife or under anesthetic, so if you're not happy, if at any point the worst case scenario you lose your money, it's better than your life, or it's better than things going wrong in a situation where you can't help yourself. So yeah, if you're in doubt, please say no. And I think there's just one more slide after this. Yeah, and I just put on there, obviously I'm an NHS GP, and I think training in somewhere like Nigeria where you don't have, publicly funded healthcare system makes me appreciate more what we have in the NHS. We all have a collective responsibility to keep the NHS going. I know it's not working for some people and it's not perfect, but honestly, you don't want to be in that situation where you're needing healthcare because you can't afford it, you don't get it. It's a very horrible situation to be in, and I'm sure we all have families. Even if you're born in the UK, I'm sure we have families abroad, and we have all these horror cases of people just being denied healthcare because they just cannot pay for it. I've been in A&Es in Nigeria where people cannot pay for oxygen, and they've been in an accident because they can't pay for oxygen, they don't get oxygen and they die on the trolley. So it's a horrible situation to be in. So let's please, we all have responsibility to keep it going. Yes, we're going abroad to have the care that we feel we deserve, but let's make sure that we're not coming to put an extra burden on the NHS and then NHS having to pay much more money than what they would have otherwise paid as well. And people get this, people sometimes think that, we're just holding back referrals because we want to. It's not because we want to. There is just a long queue, unfortunately. If you needed to be seen sooner, we would make sure you're seen sooner. It's just the situations of things, and some things are not life and death. Some things are just more of an inconvenience than anything. In terms of cosmetic surgery, it's a newer field. It's still growing. We don't know where things are going to go in the NHS. Is it ever going to become mainstream? We don't know. At the moment, most of the money is prioritized on life-saving treatment, and that's where most of the money is going for now. And I think that is the last of my slide. I've just got references which will be put in the chat for you, and that's just where I got, it covers most of the things I've talked about today. If you want to do more reading, or I'm sure this is on YouTube as well, if you want to read about it, or feel free to reach out to myself or any other doctor that to give you any insight into things that you're going to do. Thank you very much. Dr. Luca, I think you're on mute. I don't know who's here.
Yeah, sorry, I just realized I was on mute. Yeah, thank you very much again, as I was saying, thank you very much for that very insightful talk. Yeah, we learned a lot, and I think it's a topic that I guess not a lot of people are informed about. So thank you very much. We're just going to go to the Q&A section. I think you were very informative because there's only a few questions. So someone's asking if we can see the first two slides again about health tourism. And yeah, if you guys have any questions about it, about the talk, please, drop a message on the chat or on YouTube. Oh, Dr. Follow, I think you're on mute.
I think
Yeah.
I saw a question, and it's a question in about research focus on understanding how to make breast screening service more accessible to Black women in the UK. Yeah, very important. Absolutely, very important. Sorry, it wasn't a question, it was a comment. Yeah, that's very important.
I have a question.
Yeah.
Someone says, what is the procedure that is considered most dangerous for health tourism?
Ooh, do you know what? Officially, there's no statistics. We don't know what people do in different things. Medically, I would say anything that is what we call invasive, so where you have to be put to sleep, basically, because one, you don't know what's happening to you while you're asleep, so anything can literally happen to you. And obviously, there's more likelihood for things going wrong. Also, if you had to have things like blood transfusion, what is the quality of the blood transfusion? I mean, even in the UK, we heard some years ago people were transfused with, the wrong type of blood, and so yes. So any major surgery, I think the more invasive the surgery, if the major surgeries are, I would say, are more risky, obviously, than the minor surgeries because there's more risk of things going wrong.
Okay. There is another question from Zana that patient recruitment for abroad. So London and Manchester, patient recruitment for abroad. How is this practice uncovered? Um,
So
do you
there are
understand that?
different schemes. I think she means uncovered, maybe insurance wise. So there are different schemes. So I was looking at the papers, one of the papers that I've shared on there, and it was actually a big parliamentary debate, and the I think is the second link that was done in 2016. So apparently, if you want to claim for medical negligence, if something happened, something went wrong during your procedure or your treatment, you can only claim, let me put this right now, you can only claim in the country where the doctor that treated you is based, where the treatment occurred. So therefore, if you have a recruiting clinic here that says, oh, I think you need this surgery, for example. Now they say, well, you could go and have it with Clinic X in Manchester. They will cost you this. But some of my patients have gone to have it in Clinic B in Turkey, for example. Now, yes, they have referred you on to those people in a soft way, but they're not the ones that have given you that treatment. They haven't formally referred you on to there. So you go to Clinic B in Turkey and you have your procedure done and something went wrong there. You can't come and sue me because I didn't do it. I have no, I had nothing to do with the treatment, basically, so you don't have anything. The other thing I found out is some of them they have what they call like consultation hubs, basically, where they come and they do it. Some of them are doctors who are dually certified in different countries. So I'm a Nigerian doctor and I have a Nigerian clinic in Nigeria. So I can practice here and I can practice in Nigeria. Those kind of doctors might be easier to get hold of because they've got a UK registration. And even though they've practiced it in Nigeria, you might still be able to chase them, but would you be able to get anything off them? I don't know. Again, is the legality of that, because I've not done anything wrong in the UK. I've only done something wrong in Turkey. However, for UK registered doctors, you are mandated to declare to the GMC if you have a hearing or a negligence claim in another country. So you have to declare it in the UK. So for UK, you're kind of safe if they're registered in the UK. The other thing is some of the people that are recruiting are not medical doctors. So they're people who are like administrators. They take you through, periphery of it, and you say, oh yeah, that sounds good to me. Then they'll do a Skype or a Zoom call with you with the doctor abroad. They'll give you more details. Don't forget that's still telemedicine. That doctor is not based in the UK. So if anything went wrong, you can't still sue him because he's based in Turkey or in Nigeria or in India or whichever country that it is. So I hope that answers the question. If that's not what you asked, please just put it back in the comment and then and clarify.
Yeah. There's a okay. Thank you very much for that answer. Got another question, which is I'm sure we all would like to know. What are the countries you'd like to recommend to visit for procedures like BBLs, hair transplants, blood donations, and a full health check?
So I can't recommend a particular country for procedures. But broadly speaking, it's not about the country, it's about the person that is doing the procedure as well. So you can have the worst doctor in the UK and you can have the best doctor in Turkey or in India or whichever countries. They're popular destinations. Doesn't mean they're the better ones because it's just about the marketing. It's what we see on social media. We then perceive it as reality. Doesn't necessarily mean they're the best. You know, I know a lot of people that go to India for healthcare, but you don't hear about India so much. And I know India to some degree, they are quite good, but obviously I'm not recommending that you have to go to India for your healthcare. But it's going to have to be on a case by case basis, and you have to know the person that is doing it. So it's not about the country. Just as things go wrong in the UK, people come to UK for healthcare, for example, but things still go wrong. One, the person, but secondly, the system is there to absorb it. So if I did a procedure for you in one of the private hospitals and something goes wrong, I'm onto the ambulance. Ambulance is there in 5 minutes. You're in the hospital in maybe 10, 15 minutes. You're in ICU within like 30 minutes, basically. You know, if that same thing happened in another country that is not as resource equipped, you probably will not make it. So it's not so much as just the person, it's about the person, the procedure, and the resources that are available in that country as well for that procedure that you're going for.
Yeah, that's very correct. Yeah, I think it is also it just highlights how important it is that you do your own research into because at the end of the day, these people are also running businesses, so it's like very important that you learn a lot of what they have to offer before you go into it, not just on country basis. Got a question from Annette. She said, I've heard reports of people who have claimed that the waiting times for the NHS are usually longer for the ethnic minorities, which then compel them to seek help overseas. Can you please comment on this? Thank you.
Obviously I'm a health minority myself, and I totally agree with that. I think there's, the challenges facing the ethnic minorities are there are lots, and that's why these kind of things come up. And we're lucky that a large proportion of people practicing NHS are now ethnic minorities, and I think we need to start taking that challenge on ourselves to support our own people. Now, loads of things, and I think that is a whole different presentation on its own in terms of why. But I think two main things is one, as GPs and Dr. Eloka would know, with GP training, you're taught to learn things by cues. You're picking up subtle information from patients, not just what they're saying, how they're saying it, and how they're coming across. Now, because we're from a different culture, the kind of cues that we have is different from the cues that somebody else has. So, and I think, and I really don't blame my other colleagues that are not, and I'm sure I miss the cues as well in, Asian people or Eastern European people, but I can easily see it in an African because it's my culture. The way somebody says something, the way they come across. The other thing about ethnic minorities is we're quite what you call stoic. We don't, if something is wrong with us, we still go to work, we still want to do. And then we go to the GP and we kind of downplay it as well. Like, yeah, I know, I had CS yesterday, like, yes, you're dying, you need to go into hospital. I know, and I think some of these things doesn't help us as well because majority of the population is they have a pinprick and they're calling the ambulance and you're there dying and you're like, oh yeah, you know what, and I'm not saying we should play up our symptoms, but I think it's still a learning curve, and there's so many reasons. And yes, obviously there's going to be some level of bias there as well. And I'm not going to, say that, I'm not going to pretend that doesn't happen. Even I, as a medical person, I have gone to see a GP before, and I said, what I wanted. And the way I was answered, I was just like, I wouldn't answer somebody else like that if they came to see me. And I'm a doctor, I'm a GP trainee, and I train in the region as well. And the way the person answered me and they just denied me what it was. And the next time I needed it, I just went home to do it. And it happens a lot. It does happen a lot, and it is a it's a learning curve. And I know the RCGP, which is Royal College of General Practitioners, are getting actually trying to improve that communication or that cultural diversity. And we've got Dr. Margaret Ipo, which she's I can't remember where she's from, but she's African, and she's one of the the council presidents, and then she's one of the heads basically. And that just shows we're pushing more towards recognizing the fact that there are lots of ethnic minorities in the UK and in other countries as well. Healthcare has always been directed towards a particular demographic. We need to be able to accommodate that from training, from all the way from training. It starts from that. So absolutely, I agree with that. It is a work in progress, and I'm sure we'll get there. We've got communities like this. We've got lots of doctors, Asian doctors, Europe, Eastern European doctors as well. And I'm sure with that over time, things will improve.
Yeah, I agree. Yeah. So questions flooding in now. Got a question from Albert. Says, how does natural medicine feature in health tourism, especially for the Black community who are culturally more inclined to seek alternate treatments? This is on a backdrop that Western medicine or Orthodox medicine remains not very well understood amongst our community. For example, we culturally do not have local synonyms for some English medical terms. So yeah, how does natural medicine feature in health tourism?
Natural medicine in the whole of the healthcare system, it's a totally different ballgame entirely. And one of the things with natural medicine is not standardized. So unlike what we call Western medicine, right? That's what we call it in Nigeria. I don't know what other countries call it, but unlike mainstream medicine where there's standards, there's evidence base for things, there's the guidelines, there's research and everything. You can go to one country and what they call natural medicine is different from what the other country calls natural medicine. So there's so much disparity in that. Now, where does health tourism fall in that? I think it ends up being the responsibility of the person going for that procedure, unfortunately, because there's no standard, this is the natural medicine procedure for somebody presenting with this thing in this country. But if you go to country B, they give you a different type of management entirely. Now, so we've got that, and I'm just going to say, because a lot of people mix natural or homeopathic medicine to non-medical things like well-being and psychology and all those kind of other ones, which is again another social science-based thing. So I just wanted to delineate that. Now, for well-being and life, mental health or psychological, I'll say psychological services. Now, that is totally different from homeopathic medicine, because that one, yes, it's more non, well, I don't know the name to use it, but that is a bit more standardized. And in terms of health, in terms of tourism, that there's some countries that are quite big on, again, the non pharmacological, that's the word, non-pharmacological ways of practicing things. And I know places like some of the Scandinavian countries, for example, they're kind of focused on more of how you can improve things with lifestyle and with other psychological therapies rather than actually just going straight on. Again, it's not as developed as mainstream medicine. And we all know why mainstream medicine is this developed, because of the pharmaceutical companies, right? They're the ones that are funding most of the research. They're the ones that are funding a lot of these clinics and pushing a lot of things. So there's money in healthcare, long and short, the way we know it. The other ones are still up and coming things, and there's just not enough research there at the moment. Again, it's just going to be based on who you know and what information you have to decide whether that person is good enough to manage you as well.
Yeah, I agree. It's just a shame that, like, yeah, as you said, a lot of the research is that how research is funded is by money. So eventually, a lot of the research tends to be pushed by where the money is at,
Absolutely.
which,
If they're not going to benefit
which,
from it, nobody wants to know about it. Because nobody's
yeah,
going to do something for free.
yeah.
Most of the times.
Got a question about IVF. from Facebook asks about the availability of black donor eggs and sperm are rare in the UK. What is your view of IVF places in Africa? And she also asks, do you know about the success rates in places like Nigeria? And are they more likely to be flexible in terms of women over 35 in places outside the UK? And what about the likely aftercare? That's a very good question, I think.
Yeah.
Yeah.
Yeah, absolutely good. I do know people that go to Africa, Nigeria in particular. I don't have any personal recommendation that I know, but happy to reach out to me on Facebook, and I know some people that do it now. The thing with anything, again, like the other answers that I've given, you do need to know, again, it's not a general, this country's healthcare system is 100%. It's still about who is going to give it to. So you're coming to the UK. So, for example, I'm bringing somebody to the UK for a healthcare system. There's some places I will not take you to for some things, and there's somebody I'll call for the other thing. So you need to be careful who you meet for what you're doing, because it's private healthcare at the end of the day. So they do have good success rate, and the NHS, I just realized I think I missed a slide because I talked a bit about how the NHS is broken down, but I don't know where it is, and I'm trying to find it. But the NHS is built around the levels of care, basically. But because NHS is publicly funded, the money's not infinite, isn't it? It's all from the monies that we're working for and that we're paying taxes for. So they have to be efficient with the use of the money. Now, if that procedure doesn't meet a particular threshold, they wouldn't commission it, basically. It wouldn't be commissioned to be given. And there's some more specialty things like transplant, like fertility. And it used to be some cancer treatment, but I think most of them are, it's easier now. But some specialist medications, which are very, very expensive, they would only offer it to people who have a high chance of success from that procedure, because obviously they have to justify the money they are paying for that procedure. So not because somebody above 35 absolutely cannot have a baby, but it's just because somebody above a particular age is, and I think, I don't know if it's 35 still, I think it might have gone higher, but let's assume it's 35. Again, it's one of those postcode lotteries. Some areas might be 35, some areas might be more. Some areas you have to be a particular BMI as well. So if that's your body mass index. If your body mass index is higher than something, they wouldn't do it. And that's not just you and your partner. Smoking history as well, so some of them are like that. Some of them will fund one IVF, some of them will fund two IVFs, depending on where you're living. So anyway, just back to the point. So the older people are, or the heavier people are, or the more unhealthy their lifestyle is, the less success rate it is for the IVF treatment to be successful. So therefore, they have to put the money in the people that they know would most likely benefit from it. So you could go to another country, you might be, perimenopause, 48 or something, and you decide that, look, I still want the IVS and I'm happy to sign that, I'm happy to have it. And that country's law allows you to, it doesn't have anything to say the doctor cannot do it, they will go ahead and do it for you. So yes, some of the rules around the NHS it's about safety, but it's also about efficient use of resources as well. So it doesn't mean, it's not an absolute like, yeah, I can't have it after I'm 35. It's just that the likelihood of side effects and complications as well, not just that it's not successful, but also complications as well, is higher.
Mm.
And because of the safety, they're like, let's just leave, because then we're going to spend more money making sure that you are safe and making sure that you don't have any problem after this procedure. Then what's the point? It's not, it doesn't serve you and doesn't serve the general populace, so they won't apply to that. But yeah, there's some people that will still do IVF in people that are over 35. You might want to speak to some of the private hospitals in the UK as well. You might find out that some of them would offer you, if you have, healthy eggs and sperm and all that, they might still be happy to offer.
Mm-hmm. And just in addition to the end of that question, she asked whether about what is the aftercare would be like if IVF is offered abroad to people over 35. Would it, I guess maybe the question is, would they still be following you up after that, or would it be transferred back to the country that you're from?
In the ideal setting, they should follow you up, which is one of the things that, I talked about, because if you did have IVF on the NHS, You'll be managed by the specialist from, up until they show that the pregnancy has passed, I think, the first trimester, which is the first 3 months, making sure that, all the problems that can happen in the first trimester, miscarriage, and some other complications that can happen basically are not, are taken care of. You'd also be on that consultant-led care because it's a high-risk pregnancy. They'll make sure you're seen more often than the average person. You're having the scans to make sure everything goes well. Now, some people will have IVF and from the get-go, they're fine, and, they can then be stepped down. Again, it's going to be a case-by-case thing, like, okay, fine, fair enough. Mrs. Y is, she's following the right, she's doing really well. We don't really need to bring her into hospital so many times. Let her go to this clinic, lower, we can step down the risk. However, somebody else might have something different. They're like, every time they're sick, they're having tummy pain, they're bleeding, even though the pregnancy is progressing. So again, that will be high risk pregnancy that has to be managed, all the way through by the consultant. And some of them, they'll deliver them as early as possible because other things happen along the way. So it all depends. Sorry, there's no straightforward answer to this thing. It all depends. But make sure whoever you're seeing, whenever they're going to discharge you, is at a time that you're safe enough. And I would say probably have contact with them at least maybe till after the first 3 months of the pregnancy, when at the time where we expect that the pregnancy has settled in and then nothing else is, you're not likely to have any major complications until obviously when you're about to deliver, which is the other time where, what kind of delivery model are you going to have? The other thing is, as soon as it happens, because of cost and everything, you might want to come back to UK or you want to have your baby in the UK, then you will then need to be referred back into the midwife, the maternity pathway, and then they can then step it up to a consultant to look after your care. Make sure all the documents that you need and that what has been done for you is given to you. What some people do is they go and have the procedure, come back, go to work, and then they take an early maternity leave and go back and have the baby after. It just depends on how it works for you financially as well, and how comfortable the person you're working with is with that arrangement. So have that discussion with whoever's doing the treatment for you and say, look, this is the situation, this is what I'd like to do. And I think this is safe enough for you to go, then that's fine. If something is cheap, it's cheap for a reason. So just be careful.
Thank you very much for that really informative answer. Just the time has flown by. It's already 12. So I think we've had a very good, very, very good informative session. I think there's quite a few requests asking if we can maybe do this session again, because I see that people are quite interested in this. And also as well, do you have any any pages about this? I know that you said you're a travel agent and this is something that you do a lot of research in.
I don't do. I know you asked me before if I do content, because of all the things I do, I find it hard to keep content out and all that. So no, I don't have any pages, but yeah, it's something.
If anyone, sorry.
Yeah, no, that's fine.
Sorry.
Yeah, we used to actively do stuff about Black health during the COVID, and a lot of people did. But since COVID went and the pandemic went, we all went back to our lives and we don't have that page anymore, I don't think. But yeah, I mean, this is going to be on YouTube anyway. So, and if you let the organizers know if there's enough, about a particular topic, they can always get myself or one of my colleagues to come and talk to you about it as well. But I'm happy to come back and talk about it. And if there's any other questions that I've not been able to answer properly and you feel that you want looking into, I can do more research on it and come and discuss it with you as well.
Okay, awesome. Thank you very much. And Albert, thank you. We'll pass over to you to round up and show us the slides. Thank you, Dr. Fuller. Thank you, everyone, for engaging.
Just 1 second. I think Sakina has been raising her hand. I don't know if she was going to ask a question. I know she's part of your team.
Yeah, thank you so much, Dr. Folake and Dr. Enoka. We're watching here from Gotten Hub, and we have so many people that can relate. You mentioned Turkey. We have people that have gone to Turkey in this room. So, and one of them is, she said she just wants to say something in just 1 minute.
Okay.
Esther. Yeah, my name is Esther. I really wanted to say how enjoyable this session has been. It's been very informative. Definitely want to hear it again, many more of it. We'll go to Turkey. You mentioned Turkey. I didn't think you need injections for Turkey. I went for 4 or 5 days, came back. I was ill. And I was put on, they called it Polaria something, left untreated. It would have went into the serious complications. So I was on treatment for a whole month, so many different tablets. And that was Turkey. I didn't take any form of injection. I didn't go to the doctors. I just went for a few days rest. and I came back and I was ill. Tools was like water, sweats, everything, and it was really bad. So, and I really wanted to pick up on the point of I've known so many people that have gone away because of the waiting list is so long. They get impatient. They've gone away to various countries looking for other alternatives. I know a lot of the doctors will promote themselves saying that they can do this to do that. They don't verify the qualifications, past history of anything, and they end up going, having these procedures done, come back, and you're right, they do demand aftercare from their primary GP, which they don't really have to do because they didn't do the procedure in the first place. So I think the many more people that hear about this topic, it is very, very valuable indeed, because it can save so much people going into more serious complications than when they went away in the first place. So I want to just say thank you so much. I appreciate this valuable information, and I look forward for so much more of it. Thank you.
Thank you so much for that share. Absolutely. Yeah, you've hit the nail on the head. Absolutely. That is our nightmare of, of people going abroad to get healthcare. And one more thing before we go, one of the other problems we have, and I think the NHS will just have to adjust to this, to be honest, is that because of the way the funding is held, you might just think, oh, it's healthcare. I've just gone to the NHS. Nope, it's more than that. Different parts of the NHS have different pots. So if this procedure, say weight loss surgery, is in the tertiary care pot. Now you've come back and said, oh, I need this test done. Really, the money is not in the primary care. The money should come from secondary care. So what then this means, and that goes under the social responsibility bit, I'm taking the resources I should be giving to somebody who I should be treating to manage this person who has just come from somewhere, and I have no choice but to treat them. So it upsets the system so much. And some of the times you go to the GPs and they're like, and I'm not excusing people to be rude or to patient, but when there's that reluctance, it's also how many of these are we going to do before primary care collapses? Because then we can't do the thing that we're supposed to do. This older man with COPD or arthritis, and we can't manage her because all the resources is now going to this other person who's coming acutely ill from whatever country. So thank you for that great share, and I think that kind of underlines the whole talk this morning.
Yeah, thank you so much, Esther. Thank you for sharing that with all of us. Okay, I think there's one more question, final question from Ayabo. A question is, now that assistant doctors are now being licensed to work like trained doctors, so for physician associates, what can a patient do if not satisfied during the consultation with a assistant doctor?
You just need to go back and ask for somebody else. That's all. You're well within your right. Even if you saw a GP and whenever I see a patient that is not, I feel that the patient is not happy with what I've done, I say, look, you can come and ask for another doctor for a second opinion. Please don't feel like you have to. I know it's hard to get GP appointments, and I hate it when I have to get appointments for myself or my kids. But if you're not happy with what has been done, just book another appointment with somebody else just to get a second opinion. I think that's the truthful answer. Please do not go to your working center and urgent care center because they're not the place to manage it. Just book another appointment at the surgery saying you want, and most surgeries as well, if they're well run, if you're coming for a second or maximum a third time for the same problem, will not book you with a nurse practitioner or a physician associate. They'll usually book you with a GP as well.
Okay. Yeah. Thank you again for that really informative answer. Okay, now yes, I'll pass it over to Albert for the closing statements. Thank you, everyone.
All right, thank you so much, Dr. Folake. It's been a really interesting conversation, and I would actually like to pick this going forward because I know Dr. Iloka, put my question forward, and I wanted to follow up on that. The reason I wanted to follow up on that is we know that within the Black community, I mean, even forgetting everything that we've had in the past, if you look through the chat and you try to do a little analysis of what the responses are, you can tell that the reasons why people are not engaging with the healthcare system are, long waiting times, and mistrust of the healthcare system. Those are one of the reasons why people want to seek healthcare elsewhere. and not even believing, as I put it, in orthodox medicine. The reason why I'm saying that is I'm surrounded by lots of people that would travel outside of the UK, just believing that the UK is not really helping them health-wise, and so they would go elsewhere, but they'll be seeking alternate therapies. And I know you talked about it not being standardized and all, but one of the things I'm thinking about is, there are lots and lots of studies now. It's an increasingly, what's the word to use? I don't want to say attractive field in research where people are beginning to look at these alternative therapies and how helpful or how useful they are. But if we start the conversation about standardizing them, especially for the Black community, because that's where we feel, if I can speak for everyone or most people, that's where we feel, that's how we feel we'll get better treated rather than taking chemicals into our body. It's a thing within the Black community, but if we can forward that agenda, then we can start a discussion on how to make it safer for people, especially those seeking healthcare outside of the UK. I will share the closing slides if you would give me just a few seconds to do so. And just let me know if you see my screen. Sorry about that. Yep, there we go. Let me know if you see my screen. Can everyone see my screen? Perfect.
Yes, we can.
Right.
Thank you.
Right. So thanks again, everyone, for joining today's session. It was a brilliant session. I enjoyed it, and I'm looking forward to having Dr. Folake back again to join us to continue this discussion. Next week, we are delighted to be joined by Dr. Chiedu, and the Nigerians should help me with this. It is Ufodiama, if I'm correct. So he is going to be taking us through a discussion on common skin problems affecting us as Black people. So we'll be talking about things like acne, keloids, vitiligo, atopic dermatitis, hyperpigmentation, among other skin conditions. So kindly do join us again, as you've done today, from 11 a.m. to 12:15, and I hope you enjoy that one as well. We also have our Carol service. That's one of our flagship events in CAHN that will be happening in Manchester on the 11th of December. It's free for everyone. Doors are open from 7:00 p.m. and come and enjoy all the, carols. You don't even have to be a Christian to join the carol service, but come and join the family of CAHN and the Black community in celebrating this event. We're also reaching out to interested people who want to become health champions, especially for our Black women in Lambeth. If you'd like to be one of the health champions, contact Stephanie. You have her address on the screen. That's stephanie@cahn.org.uk. The remuneration for being a health champion for that project or for this CAHN project is £18 an hour. It's basically around sexual health, improving the sexual health of Black women in Lambeth. And I would reiterate again that this is something which is helpful for our women. And so please do reach out to Stephanie if you are interested in becoming a health or community champion. We're also inviting you to join our wellbeing hub in Manchester. This time we want to support our pregnant women, we want to support the children, we want to support their families. So this is happening on the 1st and on the 3rd Saturday of a month. It's happening at the Gorton Sacred Heart Family Hub in Manchester. And please do kindly either scan the QR code or click on the link. The slides should be available online if you're not able to capture this now. But please do either scan the QR code to find out more or click on the link. We also have our family and advocacy support sessions, which is on the second Wednesday of every month. It happens at between the hours of 6 and 7 p.m. It's the next one should be happening on the 13th of November. Again, you can click on that link to register. Registration is free, and we look forward to seeing more people on this project. We also are inviting everyone. This year in particular is one of the interesting times within the NHS where they are trying to improve on their services. I have been part of one such initiative trying to improve the language translation services within the NHS. Everyone's voice is needed. The NHS is reaching out. So if you want to see change within the NHS, this is one of the opportunities to do so. And you can just scan the QR code to make your voice heard. We also are sharing an opportunity with CAHN. So CAHN is one of our partners, and especially as we are going into the winter, we need to warm up, and CAHN is happy to have partnered with them to help our community in keeping warm during these cold times. So as the temperatures drop, to do so, text warmth, WARMTH, caps, text warmth to 85258. And the service is 24 hours, 7 days a week. We hope to hear from you. So from all of us at CAHN, we thank you so much for joining us today. It was a brilliant session, as I've already said. We're looking forward to having more experts from the field, more doctors, more Black doctors, more Black professionals come and share their expertise with us, and for us to have a fruitful discussion. Thank you all, and we hope to see you next week. Thank you.
Welcome to our Caribbean and African Targeted Health Improvement Program, CAHN Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CAHN is funded by the National Lottery Community Fund.